So thanks to all of you for joining this new series in ECHO for the fall. And we have a different theme this time around. So we have focused our prior ECHO series on specific conditions: diabetes, hypertension, obesity. This one deals with cardiovascular innovations and is entitled "What's New in Cardiovascular Prevention?" A series of case-based discussions. And it's the first time we're doing this, so please bear with us. We have a terrific schedule, some great faculty will be presenting the series as well, and we've got some wonderful cases as well. So thank you all for joining us. I see a lot of repeat customers, which is always a good thing. So they had a good experience last time. So Rick, next slide, please. One of the most important things to keep in mind as we go through this series and introduce our cases is to avoid any discussion of personal health information. So names, even location, try to avoid it. The convention that we've adopted for this series is really just to use initials for patients. They don't even have to be accurate initials, but just use initials when you're describing patients as you go through this, or nothing at all. Next slide, please. So if you have any concerns during this series, we have a number of people who can support you. Rick is here on the call this morning for any troubleshooting and IT support. You've probably run into him already in terms of checks prior to the series. You can email me anytime you wish. And in fact, just as a principle, ECHO is a community of learners. It's not a one-off. It's not like you flying to Las Vegas to go to a CME course and then you never really interact with the faculty again. That's not what it's about. It's about us learning together. And therefore, I think questions are not just expected, they're welcome. And I've learned a great deal by having done this for a number of years. Claire is our new clinic coordinator and has already done a great job in organizing this series, and she's always available for scheduling, timing of case studies, etc. So don't hesitate to contact any of us anytime you wish. Next slide. So Cardio was founded in 2017. So we've been around 5 years, almost 5 years now, I believe. And the mission is to improve cardiovascular and diabetes health outcomes and eliminate disparities in Ohio's Medicaid population, whom we all care for. So it's an initiative run through the 7 medical schools across the state. We identify, produce, and disseminate best evidence and best practices with a strong focus upon implementation. So yes, it's one thing to evaluate evidence. Implementing it in practice is another thing. And the analogy I always give to people is that just because something is the newest and best evidence doesn't necessarily mean you should grab onto it right away. It's like the new iPhone comes out. There are some, fanatics who will line up to get it. That's not necessarily the best thing. Maybe you want to wait a while and see how it works out or how best to incorporate it into your lifestyle. So think of evidence that way as well. In addition to cardio, we have monthly newsletters. There's a repository of resources, one of which I'll refer to today, podcasts available. A lot of these ECHO sessions, of course, recorded. This one is recorded and available for you to review at any point. Next slide. So I just want to briefly go through the cardio team and who we are. So I'm the director of the ECHO program here at Cardio, have been for 5 years, and was the director of the ECHO program at the University of Chicago in pediatrics for about 8 or 9 years prior to that. So this is like, been doing ECHO since I think 2010. So quite some time. We have a number of didactic presenters today. Liz from Ohio University will be presenting briefly on appropriate language, and I'll be presenting the main content today on home blood pressure monitoring as well. We have a panel of content experts. Now, our panelists are here to provide specific commentary on our case studies, but also are here to help guide the discussion that follows the case studies, in which you may have particular questions or comments you'd like to raise, and they will participate in that as well. And they consist of Kristen, Danette. Kristen has expertise in disparities, Danette in behavioral medicine. Adam, again, has a lot of expertise in health disparities as well. Jim is a behavioralist I work with closely. Jackson Wright, of course, is a renowned nephrologist, and here in case studies and has a lot of expertise in hypertension. We have people who have really a lot of great hands-on experience, like Mary Lee Clemens, From the pharmacy angle, Kathleen Dungan's an endocrinologist at Ohio State. Chris Taylor's a PhD nutritionist who we asked to comment perhaps a bit too often. He's often up to provide commentary. Karen as well is a frequent commentator on our case studies. She's a certified diabetes educator. And Liz, whom I think Liz will ask you to introduce yourself as we get to the next phase as well. Next slide, Rick. So these are our participant sites for this fall series. One of the most important priorities for ECHO is to have representation from across the state. And we have consistently achieved that. And it's not just related to the 7 medical schools, but we have sites that are affiliated with medical institutions that are in rural areas or in urban areas. So Austin Friedrichsen, for example, is in Salem. It's an affiliate of Neomed, but he's in a very small town. And certainly here, the folks at McDonald Hospital, for example, care for a economically disadvantaged inner city population. So quite a diverse group of participants this time around and consistently over the last 5 years or so. Next slide. Disclosure statements, these will take place per session. So in other words, when it comes to specific content, people might have some disclosures, but these are our general disclosures as well. My only disclosure is not pharmacy related, but I serve on the board of Goutham Rao, which is a French yogurt company. That's a long story, but and the others that are involved, as it says, don't have any financial disclosures of any kind. Next slide. So I want to turn things over to Liz, and she's going to guide us through some patient-centered language recommendations. And of course, you know, these are somewhat new to some of you. I think it takes a while to get used to these and to practice them. I think I've gotten pretty good by now, even though I could still use some improvement. So Liz, please take it away.
Thank you, Dr. Rao. Good morning, everyone. It's great to be here. As Dr. Rao said, I'm at Ohio University. I'm the co-director of the Diabetes Institute down there. I work with Karen Bailey. The work that I do is I'm a researcher, so I focus on rural health and in particular diabetes in rural Appalachia. And I have a particular focus on psychosocial issues in diabetes. Next slide. So today I'm going to very briefly review patient-centered language. I'm going to do this in the context of health, but also when we're talking about participant demographics and how you might present your cases. So we know that there's been a big movement in recent years towards patient-centered medicine. And so, of course, you would expect when you're talking about patient-centered care that there should also be patient-centered language. So there have been a lot of medical organizations that have put forth new guidelines on patient-centered language. Of course, the American Diabetes Association has made a big push. And this is not just within the American Diabetes Association and and I like to call it AADE because that's easier to remember than the Association for Diabetes Care and Education Specialists. But it's also like the International Diabetes Foundation, Diabetes Australia, Canada Diabetes. So this is something that's happened globally, not just within the United States. And then we have the American Psychological Association. The AMA has also been making these recommendations. So I'm just going to briefly refer to a handful of these things that I think are particularly relevant. So let's talk about gender. So gender is a social construct. It's also a social identity. So if you're going to present gender, make sure you're referring to it as a social group. If you're going to present sex, make sure you refer to it as assigned sex or assigned sex at birth. When talking about race, race is also a social construct. We use it very broadly to categorize people based on physical characteristics or behaviors or geographic location. So it's really important that we refer to this as a social construct if we're going to use it. Race does not have any association with biology or genetics. And so it's just really important to make that distinction. Now, this doesn't mean that race is not an important thing to use. Race is important because we can use this when we're talking about it at population health. We can look at race as a variable to see if there are disparities within certain groups. When talking about sexual orientation, use the term sexual orientation rather than sexual preference or sexual identity, because people choose partners regardless of sexual orientation, but sexual orientation is not a choice. Thinking about disability, this is something that's going to come up a lot with these with this series for the echo, as well as some of your case presentations. So disability should be indicated when it's relevant, but the language should always be to maintain the integrity of the individual. And also, if you know the individual, be sure to use their expressed preference for the disability. When talking about socioeconomic status, provide detailed information about the person's income rather than saying that they are poor. State their education level, then rather than saying that they are uneducated, you can state their specific occupation or employment. So it's really avoiding these pejorative terms or generalizing terms such as saying you're homeless or saying that you're poor. And then one of the new interesting things that I've come across recently is things such as avoiding violent language. And so, our colloquialisms that we have is a lot of the time we say things when we're expressing it, or if you say someone did a good job, you say, oh, you're killing it, or, why don't you take a stab at this case? And this is actually very triggering language, and there are recommendations now to not use language like this. So avoiding things like killing it, pulling the trigger, take a stab at it, or off the reservation, because there are negative connotations and they can be quite offensive. Next slide. So I put together this table. Some of these are diabetes specific, but I also tried to weave in things that would be relevant coming up in the cases, as well as the didactic sessions. So I put the few terms on the avoid section and then ways that you could change those. So, and things to avoid would be saying suffers from. It's a very negative connotation. What can you replace it with? Lives with. Avoiding the identity specifics, diabetic, schizophrenic, or saying drug user. Just replace it with the disease state itself, or saying someone who uses, because a person is much more than what they're doing. Rather than labeling a value judgment on, for example, someone's A1C, just state the A1C level or state their blood pressure reading. We're going to be talking about body weight, I'm sure, a bunch throughout this series. So rather than labeling someone as obese or morbidly obese or fat, just state their body weight or their BMI. I'm sure most of you know we've moved away from the term compliance. We're also moving away from the term adherence. And so now the new term is medication taking. That one will take a while to get used to. I'm still getting used to that one myself. Another one is regimen. So this has come from patients. So patients have said they don't like using the term and hearing that they're told being put on a regimen because it sounds like they don't have a choice. And so plan and choices are much better. Test, is recommended because is not recommended because it implies failure. So monitoring is better. Control, a lot of people don't have complete control over things. It also imposes that they are at fault if they're not reaching target. So managing is much better. And then we know with cardiovascular disease, with diabetes, that there is a strong connection with emotional well-being. And we might talk about some of these behavioral health issues. And so one of the important things is if we do discuss suicide, rather than saying committed suicide, the proper terminology is now died by suicide. So my piece in this is to just strongly encourage you to use patient-centered language. It is very difficult. This is something that we have learned some of these terms, 20 years ago, and it's really hard to unlearn things that you've been saying for years. It just takes practice, but the importance is knowing that language has an impact on someone's well-being, knows that if you can make that change, you can then influence their well-being and some of their outcomes. So I'm going to pass it back to you, Dr. Rao.
Thank you, Liz. Rick, next slide, please. So this is our first session, and the title of the series is Cardiovascular Innovations. And this is new things, new ways of thinking. We're not always going to be on the cutting edge, but I think we'll be on the cutting edge as far as implementation goes. In other words, how do we implement some of the things that have been around for a very long time? So this session is on home blood pressure monitoring. I think, as you know, I mentioned I'm the director of ECHO. I'm also the chair of family medicine and community health at University Hospitals and Case Western Reserve University. And I have a hospital title, Chief Clinician Experience and Wellbeing Officer, which most places call the Chief Wellness Officer. This does not deal with the wellness of patients, but actually of physicians, which is far more challenging sometimes. Next slide, please. So I have three objectives today. First of all, to come up with a minimum of 3 indications for home BP monitoring. And there are no hard and fast rules about this. I'm going to establish a few principles later on, and some of the advantages and disadvantages of home BP monitoring compared with clinic-based monitoring. and describe where and how patients can obtain home BP monitors. And our team best practices, and specifically Doctors Wright and Bolin, have put together a wonderful handout to help you with this as well. Next slide. So this is my own experience. So I have kind of an interesting career. I was in Pittsburgh for, as some of you know, for a very, very long time. Did a fellowship there and stayed on for 15 years. And I was actually in the Department of Pediatrics for 9 of those years as the director of a pediatric obesity center. And I got interested in hypertension in kids because, the medical school would send you these students saying, I want to do a research project. And you're like, oh my gosh, where am I? What is this guy really going to do? I don't have time for this sort of thing. And we all go through that. But this guy was really, really quite keen. And he said, I'll do anything. I'm really interested in the topic. So I sent him to one of the primary care pediatrics offices to do some chart reviews of blood pressure in children. And he comes up he reviewed 30 charts, and there was one child who was 12 or 13 years old, African-American boy, whose blood pressure over the course of 2 or 3 visits was 180 over 100. There was no note in the chart about this blood pressure. Everything else was perfectly well looked after. His immunizations were up to date. His asthma was under control. Somebody had even addressed his weight. There was absolutely nothing in the chart about this. And I said, hey, we have a problem here. So I got interested in improving diagnosis of hypertension in children in the early 2010s or so. And I was a PI of a grant based in Chicago to do this as well. But it got me thinking about different ways of measuring blood pressure around that time. Next slide. So as part of the Improving Diagnosis of Hypertension in Children grant, we had to train medical assistants and nurses on how to take blood pressure in children, which I've been trying to do for 20 years. I've almost given up. I'm not quite there yet in the office. It is not easy. So we invited a bunch of kids. This is my colleague, Kate Curley's son. He was 6 years old at the time. He's about 13 now. And he was the only kid. My own daughter was running around like crazy. She was not cooperative. They were all 6 and 7 years old at the time. He was the only kid who was able to cooperate. Rick, can you just play this? So you can see that there's no video of him with the cuff on, but you can see that he is seated calmly and is ready to have his blood pressure taken, and it actually likes having his blood pressure taken for some strange reason. So this is the ideal, but for the most part, it is extremely difficult, and that's what we learned from our medical assistants. It's about 9 to 11 minutes on average to take a blood pressure, and even then, the values are not all that helpful. We don't know. The kids are very curious about the cuff. Some of them are frightened, etc. And so I went to give a talk in New Orleans, New Orleans or Jackson, Mississippi. I don't recall which one. And there was a Japanese gentleman there who has become a research colleague and says, we gave up on measuring blood pressure in kids in the office completely years ago. I said, oh, in fact, we don't even bother with adults anymore. He goes, and I said, really? Yeah, those values are pretty meaningless. We measure blood pressure in adults at home and in children at night when they're sleeping. We have a cuff that inflates very gently. A mom just puts the cuff on, child brushes their teeth, she presses a button, and bingo. And the next day we have values that are meaningful for us. And I thought to myself, why aren't we doing more of this here in the United States? Next slide, please, Rick. So essentially, having looked at all the evidence and having served on a number of committees with the American Heart Association, et cetera, to deal with this issue, here's the basic conclusion. Every single patient with hypertension should be measuring blood pressure at home, preferably twice a day for at least 3 days, or longer, not all the time, but there's some huge benefits for patients who do this. First of all, these values are more meaningful and more accurate. They are better correlated with 24-hour ambulatory blood pressure monitoring, which is the gold standard for a diagnosis and for decisions. And they are better correlated with cardiovascular morbidity and mortality as well. So if that's not compelling enough, there is strong evidence that HBPM, home blood pressure monitoring, encourages patient-centered care. And you may have some notion of this yourself among the patients you care for. Consider the issue of diabetes. Let's say Karen is seeing a diabetes patient And then the patient asks her, what was my hemoglobin A1C last time? Because I just got the lab result in my inbox portal and it said 7.3. Was it better or worse? You know immediately that that's a patient that is well engaged and in their care and is knowledgeable about the issue, right? So it applies to blood pressure as well. If a patient can come in and say, I've been checking my blood pressure in the mornings and my systolic values are running around 150. Well, that is quite different than a patient who comes in every 3 months and has their blood pressure taken in the office. And that becomes the basis for our decisions. So it does promote patient-centered care and empowers patients as well. There is strong evidence that it improves patient outcomes, okay? How does it do that? What are the mechanisms? Well, there's two ways. First of all, we have more, as clinicians, we have much more data to act upon, right? If I take, we have blood pressure all the time and we measure it every few months or every few weeks. But if they come in with a reading or if they bring their machine in and I review the averages, that's more meaningful data and I can act upon it and hopefully improve outcomes. Also, patients themselves can act upon it in meaningful ways. So Jackson and Mahbub Rahman and I have just submitted a proposal to PCORI, which is the Patient-Centered Outcomes Research Institute, to actually start to make decisions. One of the interventions involves making decisions based upon home blood pressure values. But patients can start to say, well, gosh, I think it's because I had too much to drink last night, or I had this big salty meal and I took my blood pressure afterwards. So that awareness, that knowledge of your blood pressure can be helpful in terms of long-term management. Now, HBPM devices are very inexpensive. I mean, I did a little survey of Amazon. Now, there are some that are $14, $16. I don't necessarily recommend those, but there are well-validated devices from companies like Omron and Welsh Allen, et cetera, that start around $25 or $30. You can go to a pharmacy and buy one, or you can buy one online. 2/3 of adults with hypertension already have a device at home. Doesn't necessarily mean they use it properly or regularly, but they already have a device at home. So the accessibility of these is really quite high. Contrast that with ambulatory blood pressure monitoring devices, which the validated devices are monopolized by a couple of companies. They cost $2,000 on average. My colleague, Tammy Brady, and I at Johns Hopkins have had some negative experiences with issuing these to adolescents. Sometimes they don't come back, and sometimes they get damaged. And of course, that's a big problem as well. And also, ABPM is not nearly as accessible. Later on in the series, we will hear from Dr. Ian Neeland, who actually interprets ABPM here at University Hospitals in Cleveland. The problem is that the device has to be picked up in specific locations. It's a very, very cumbersome approach to it. So these are much, much more widely available. Now, they are relatively easy to use. It does not mean that our patients are currently using them correctly. Sometimes the batteries are low. Sometimes the cuff is the wrong size. Sometimes they can't find the device, or they're not sure where to put the cuff. But it's easy to train patients to do this. And the best way, I think, to train them, first of all, is in the office in front of them with a clinician, a nurse or a physician or someone else who understands the process. It's not difficult. But if you don't have time for that, you can text a video like this one to the patient's cell phone. And I think a nice way of doing it is, okay, I'm going to go get your prescriptions ready, or I'll be back in a few minutes. What's your cell phone number? Or put this up on a computer screen if you have it. Can you watch this video for me while I'm gone? Okay, they'll watch it. Did you watch the video? Do you have any questions about it? Do you think you can do this? And invariably the answer is going to be yes. It's also consistent with remote care. Now, I know this is less of an issue in recent months, although I don't think we're out of the woods yet. I think COVID is here to stay. Some forms of remote care are also here to stay. I'm not a huge fan. I've had a couple of bad experiences with patients who had some acute illnesses whom I saw through remote care. However, this part in particular, managing chronic disease, I think, is an acceptable form of this as well. So a number of devices are able to transmit blood pressure values. The one that Dr. Rahman has subcontracted with for the purpose of our grant, actually sets up the devices at home, trains the patients, and encourages them to take blood pressure according to a protocol, and that information is automatically transmitted to a remote database and even into an electronic health record. So it's pretty amazing that all of this can take place remotely. Here's the thing I'm most passionate about. It is that it promotes health equity. So we know that healthcare disparities are a serious problem in this country. And anything that levels the playing field for patients who are economically disadvantaged, whether they live in rural areas or inner city areas, I think is always welcome. So you're providing patients with an inexpensive tool to empower them to better manage their hypertension. The alternative is for them to come into clinic with all the transportation and logistical challenges that entails every few months, and for you to make quick decisions about how to modify their medications, I was going to use regimen, Liz, but we'll just call it medications for now. And that's not really a way to promote health equity, right? And I think that this is a way, because it is providing patients with valuable health education. It's empowering them to manage their own disease. And it is obviating the need for in-person visits to some extent. Next slide. So the health equity part is really important for us to consider. And if that's not enough knowledge for you, if that's not compelling enough, I think this paper from a very prestigious publication, Health Affairs, I think highlights some important studies that we should keep in mind. It's entitled Promoting Health Equity and Eliminating Disparities Through Performance Measurement and Payment. And of course, it deals with the provider or physician side of things. But here's an interesting fact that I highlighted here on the paragraph on the right. The interventions consisted of telephonic lifestyle and dietary counseling by trained nurses, along with the use of home blood pressure monitoring devices. The program increased the frequency of self-monitoring for African Americans and improved systolic hypertension control by 50%. Okay. And here's what I want you to keep in mind. When we implement programs to improve blood pressure control, these can be QI programs that encompass a number of interventions that have been proven to work. Provider education, pharmacy management, health education, community health workers, empowering patients through other means, maybe prompting patients to ask questions of their physicians. What among all of those interventions, the biggest share of improvement in control is just prescribing a home blood pressure monitor and teaching a patient how to use it. That's like half of the improvement that you see. If you do nothing else, if you just prescribe the home blood pressure monitor and say, hey, watch this video, you are likely to promote greater blood pressure control and greater improvement in blood pressure than, for example, to add another agent. So it's such a simple intervention. It's inexpensive. There are so many benefits. And that's why I think it's important for every single patient with hypertension to do this. Next slide. So let's talk about indications, advantages, and disadvantages, which I mentioned as part of the objectives here. The American Heart Association has a statement on this. I was not on the statement committee for this one. The indications are deliberately broad. White coat hypertension is the big one. So many patients, for whatever reason, have elevated blood pressure in the office, and it's quite normal in other settings. It's not clear why that's the case, if it's that they're nervous or tense or that they're active or they've had caffeine, who knows what it is. In children, this is half of the children that come in with hypertension have white coat hypertension. There's also the phenomenon of masked hypertension, which we see far less of. It's the patient who says, I went to, and I know you're from all different parts of the state, but Giant Eagle or Kroger or whatever it happens to be, and I had my blood pressure and it was high. And then they come into the office and it was normal. Well, that's masked hypertension. So it's hypertension in other settings. Now, both white coat hypertension and masked hypertension are not completely benign phenomenon, but they are certainly far more benign than sustained hypertension. The other indication is as an alternative to ABPM. When you think about the process of obtaining an ambulatory blood pressure monitor reading for 24 hours, it is not easy. I have to refer here, and I don't think it's that different in other healthcare systems. I have to refer the patient to ABPM. Then they have to travel to an office in Beechwood, which is actually where I have another office, but that's where they have to pick up the device. There is a nurse there who will teach them briefly how to use the device. Then they go home. They will put the monitor on for 24 hours. It has to be on the whole time except when they're showering or bathing. I've tried a number of devices, and at night it does wake me up. I've tried like 3 different devices, and when you wake up with an ABPM monitor in the middle of the night, I'm not entirely convinced that blood pressure reflects your nocturnal blood pressure accurately. Now, there's wonderful advantages of ABPM because you can see if they have your blood pressure goes down at night, and if that doesn't happen, that's a serious problem. And of course, you get an average value. Then they have to drive back, or somebody has to drive back on their behalf to the location, return the device in good condition. And then there is the issue of insurance coverage. And most of you have probably heard that Medicare is now covering ABPM. Not all commercial insurances cover it as well. And of course, then there's the fear of the device being lost or damaged or simply not returned for whatever reason. And so this is a challenge for us. So the other indication really is monitoring and medical decision making. So we talked about the patient side of it, which I'll get to again, but you can make decisions based upon home blood pressure values, right? You can have a patient who comes into the office. Perhaps it's not just purely for hypertension. Perhaps it's for something else. Maybe it's for diabetes. Maybe it's for low back pain. And their blood pressure is high when they come in. And they're on 2 agents or 3 agents already. And you can say to the patient, I don't really think I want to add another agent or increase your dosage of any of the 3 agents you're on right now. Instead, I want you to do something for me. I want you to check your blood pressure twice a day, morning and late afternoon or evening for 3 days, and maybe write down the values that you get. Most devices will store the values automatically, but if it doesn't, it's actually helpful. And maybe you could come back and share those with me, and then we'll make some decisions together about what direction to go in. So it can be extremely helpful from the medical decision-making standpoint. And the last thing I think is it does really empower patients, right, to manage their own health. It's no different than having a blood glucose monitor or a bathroom scale, not just for obesity, but for heart failure, et cetera. When you can monitor your illness, it improves patient outcomes, and that's consistent for any chronic disease. You ever teach patients to use a peak flow meter for their asthma, which has red, yellow, and green indicators on it, and you say, well, if your peak flow falls into the yellow zone, we want you to double up on your steroid inhaler, and if it falls into the red zone, we want you to call us and to come in before you need a hospital admission. It's similar with blood pressure, of course, not quite so dramatic. So that is a significant form of empowerment as well. Next slide, Rick. So how do you do it? There are different protocols. George Sturgio, who is based in Greece, has probably published 1,000 studies on home blood pressure monitoring. So you do 2 readings in the morning and 2 readings in the afternoon for a minimum of 3 days and preferably 7 days. 2 readings are important because it'll average the values for you. It's interesting that the standards for HBPM and ABPM are not the same as our clinic values. So we have the 130/80, which is identical for daytime HBPM and daytime ABPM. At night, your blood pressure is expected to drop. If you are a non-dipper, which means that your blood pressure does not drop overnight, that unfortunately is a marker of serious cardiovascular risk. Not coincidentally, a lot of heart attacks take place at 8 a.m. or 7 a.m. as a result of that. So in general, blood pressure is lower at home. And there are these are rough guidelines for blood pressure. I don't think this is all worth memorizing or remembering. If you have modestly elevated blood pressure, let's say somebody's coming into the clinic at 140/90, and you're not sure about whether you want to increase the dose of the medication or change medications around or add another agent or something of that sort. You could probably do an HBPM. And if it's in this range here or lower, you can probably say, I think you're probably okay. And it of course saves the patient a lot of trouble in the form of new prescriptions and making their medications more complicated. Okay, so how do you prescribe one? So I strongly recommend the handout that Doctors Wright and Boland prepared and actually used it in preparing for this talk as well. So every region of Ohio has a list of durable medical equipment providers for different Medicaid management plans. I believe this is Buckeye, the Buckeye plan. So here in Northeast Ohio, we would use Edge Park. How do you do this? You can go into your electronic health record, print out home BP monitor, and then fax it to this number right here. Yeah. So just as a prescription, fax it. What I don't recommend is just sending it to a CVS or a Walgreens. They may not be able to issue it to a patient. Now, some pharmacies can. For example, this is a pharmacy in Columbus where you would, if you have Epic, for example, you could prescribe it and send it directly to Crosby's Drugs and to a number of places as well. So that's probably the protocol for it. And they can get whatever is covered. Now it says here, enter the manufacturer name. I don't think most of our Medicaid beneficiaries would have a lot of choice. I think there's only one or two options. So I don't think that's absolutely necessary, but the code is this for home blood pressure monitoring as well. So I encourage you all to do that if your patients don't have a monitor. If they do have a monitor, they have hypertension, ask them to bring it in next time that they come in. And let's see how they use it, teach them how to use it. And actually, I find that when I have done that, patients are actually not just receptive to it, but they're somewhat enthusiastic about it because they get numbers that are valuable and they will ask you questions like, well, what should I be looking for? When should I be doing this? So it does really empower patients significantly. Next slide. Okay. So that is the didactic portion. We are going to move on to our case study, which is a sample case study. But before we do that, I can take a few questions before we move on. Okay, I guess that's a good thing that there are no questions. But okay, we are almost out of time. Thank you so much. I know there's a number of other questions, and that's actually what we want. We want a lot of interest in one particular case. So I'm going to turn things over to Claire to do our wrap up today.
Sure. So you can see on the screen here, there's just some links. We record all of these clinics, so you'll be able to log on and watch them back. And then Rick also edits them. So we edit videos and we take out all of the case study and the discussion and we post them publicly. So other people can see kind of what the clinic's about. And then we have all of our archive clinics as well on our website. Next slide, Rick, please. There should be a post-clinic survey in your inbox. If you can fill it out, it's very quick by tomorrow evening. That way we just have some feedback, kind of what you learned, what we can do different. And if I have not received your case studies, if you could please send them to me. If you do not have your link, let me know. I will reach out to those of you that I am missing. We are building the schedule, so I will be in touch with all of you to let you know when you're presenting your cases by tomorrow. Otherwise, I think that's it. Thank you for joining us, and we'll see you guys all next week.
Thanks, everyone. Have a wonderful, wonderful day and great weekend. Bye-bye.